Hi, my name's Amy. I'm a registered nurse for Dr. Duncan Taylor, who's a plastic and reconstructive surgeon in Perth, Western Australia. Dr. Duncan Taylor will now discuss the key points of autologous or own breast tissue reconstruction. This will include what your perioperative process looks like, your hospital admission and your outpatient appointments. This will include the risks, the advantages and the disadvantages of autologous breast reconstruction. It will also include discussion of breast revision surgery and what this might look like. You'll gain a comprehensive understanding of what the perioperative journey looks like for patients undergoing autologous breast reconstruction. We hope this guides you and your loved ones throughout the process.
My name is Duncan Taylor. I'm a plastic and reconstructive surgeon, and I have a subspecialty interest in breast cancer reconstruction and breast aesthetic surgery. Autologous breast reconstruction relates to the use of your own body tissue, and it's transplant of a piece of tissue from one site of the body with its blood vessels to another site, being the breast for reconstruction, with reconstitution of the blood flow, which relates to the microsurgical component of the procedure. The journey for any form of breast reconstruction starts with your preoperative consultation. And if we think about autologous reconstruction, how that journey may proceed is initially with a referral from the breast surgeon who is dealing with your breast cancer diagnosis, then a discussion and a relationship in terms of the type of cancer, the requirements of the cancer treatment, and what different options can be performed, ideally would occur in the very short term after the cancer diagnosis. Following on from that, if an autologous reconstruction is planned, and that's to be an immediate reconstruction, for example, the patient would have an early consultation, and then a second consultation to discuss any questions or concerns which were raised from the initial overview of what might be best managed. We have a specialist nurse who's highly qualified in this area who would discuss the preoperative, the perioperative time of surgery and postoperative plan with you. This is all done before surgery. Surgery commences, and if the reconstruction is done at the same time, then the reconstructive surgeon would perform the reconstruction immediately following the mastectomy in the same anaesthetic, in the same sittings. If the reconstruction is to be planned for a later date, then even though we may have met and made discussions, that primary surgery would be performed and the reconstructive surgeon would be on standby and liaising with the patient for a more planned longer term reconstruction. And as the patient recovers from that initial surgery, if everything has gone well, then they'll be discharged from hospital routinely with a single breast at day 4 or 5, or with a bilateral or both breasts on day 5 to 7. We would then, the patient would be discharged home with advice. Commonly they would have dressings and supportive compression garments, and potentially suction dressings on the wounds to stabilize the soft tissue. They would come back to us at 1 week, and the wounds would be assessed and the progress would be assessed at this point. They generally have another appointment a week later, and most commonly wounds are healing well at this point and require only simple dressings. If there was any wound healing issues or problems, then obviously we take necessary action at this point. Assuming all is going well, they would then see the reconstructive surgeon at a 4 to 6 week period, who would look at the shape and the quality of the reconstruction, which generally is fairly well formed at this point. So you can have a pretty good idea about how the long term is going to look like. There is a situation where after a reconstruction, the reconstruction may sit in a higher position or a fuller position, or may not be as voluminous as the contralateral breast or the other breast, if it's a unilateral situation, because of the tissue which is available. And there may be the requirement for secondary surgeries or revisional surgeries to create a more symmetrical appearance. And this can either be done in the form of volumizing the flap in certain areas, or reducing the weight of the flap in certain areas, and this involves either liposuction, which is removal of fatty tissue, or fat transfer, which is the placement of small amounts of fat to improve contour and shape, or it may involve symmetrization surgery to the other breast to lift the other breast or volumize the other breast to create a more natural and symmetrical appearance. These procedures, which are symmetrizing procedures or secondary revisional surgeries, are really done for optimizing the end result and to create as much natural symmetry and as much equivalent volume and shape in terms of the reconstruction. They're smaller in nature, often done as a day case or a single night in surgery, and are much less involved than the primary tissue reconstruction. The advantage with regard to using your own piece of tissue is that once that tissue is there, then the shape of that piece of tissue can be changed, because the tissue will always be with you, and it can be shaped or changed to create the most aesthetic and best outcome that is possible. It's not always required, but in certain situations that can give the most preferable results. Normally, revision surgery is done 3 to 4 months following the primary surgery, which allows the tissues to soften and settle and mature a little bit, and then any secondary or symmetrization surgeries which are required are done at that point. The advantages are that you are using a piece of your own body tissue. There's no rejection in terms of this. And once the tissue has integrated after the first few weeks, then that piece of tissue remains with you and is part of you in a natural effect for the rest of your life. The tissue, as it settles and matures and has taken within its new site, has a much more natural feel. It's soft, it's warm, and it behaves in a more natural way with movement of the body, movement of the chest wall. It also provides good vascularized tissue between the surface of the skin where the mastectomy has been preserved, and the chest wall, which means that the scar tissue buildup within the breast is reduced, and therefore any pain and discomfort associated with this is more minimized. The disadvantages of autologous reconstruction relate to the complexity of the surgery and the fact that it involves microsurgical technique to reconstitute blood vessels as you're moving a piece of tissue from one site to another. This means that the surgery length is a little longer, in the region of 4 to 6 hours for a single breast or 5 to 7 hours for 2 breasts. That means that the general anaesthetic which a patient is experiencing is commensurate with this timing and therefore a little longer. The other major disadvantage is that you have to take tissue from one side of the body and transplant it to another, and therefore there's where the donor tissue has been taken from, there is a scar. However, with recent more advances in the capabilities of raising these pieces of tissue, there is now very little damage to the underlying musculoskeletal structures of the body, such as the abdominal wall. The risk of an autologous reconstruction not working is, in the international literature, in centres and specialists that do this procedure very regularly, in the region of 1 to 2%. This is generally a total failure. If the reconstruction doesn't work, then it's a complete loss of the piece of tissue. The percentage is very small. Before that situation would occur, then we take a lot of precautions to monitor the tissue and to check that those blood vessels are working and that piece of tissue is happy and comfortable in its new site. And in order to do that, patients have a high nursing care input, and the flap is monitored to check the blood vessels are working on a 15 to 30 minute basis for the first evening into 24 hours, and then those observations are slowly reduced as the potential likelihood of it not working reduces over time, over the first 48 to 72 hours. If the reconstructed breast, the autologous breast reconstruction did fail, and it was not able to be salvaged, then this is not the end of the line. A lot of people feel that there is only one opportunity to have your own tissue used for breast reconstruction, and if this opportunity is used, then there is no other options. This is not the case. Actually, there are other body sites which are suitable donors for breast reconstruction, and they can be used to reconstitute the defect which has subsequently arisen from the failed flap. Autologous reconstruction now is a very well recognized and well practiced procedure, and with specialists that are performing this procedure regularly on a weekly basis in institutions that are set up for performing this, this really is the gold standard of breast reconstruction, and now is performed as a routine procedure.
We hope these videos have been a valuable resource to you. For more information about what breast reconstruction options and resources are available to you, please visit Dr. Duncan Taylor's website for more information.